Okay. That's better. So I'm going to talk to you guys about something we see quite a lot in the A&E department. Sorry, when I'm showing my slides, I can't actually see anyone's face or anything or any of the comments for some reason. So if you've got any questions, please put them in the chat. This is meant to be a really interactive session, and we're going to go through quite a lot of cases that we'll see in the ED. So please do turn your mics off and feel free to ask questions as we go, or if I'm going to ask you guys some questions, and it'd be nice if we could have a bit of a response. Is that okay? Great. So we're just going to go through some clinical cases, and I really want to just highlight what things not to miss, because that's when I was at your level, I just didn't want to miss the things that I shouldn't miss. Okay, so I think it's always good to have a bit of a way of going through in your mind, so you don't miss things. So like an aid memoir or a surgical service can be very helpful. I'm sure you've all got one. Not to preach which one to use, whatever you use, I'm sure is fine. Okay, right. But so you think about lots of things when you're assessing patients, because it's good to go wide in your differentials before you narrow down. Yeah, because otherwise we miss things. Okay, so our first case, a 13-year-old young person comes with a headache on the right side, feeling a bit sick, a bit unsteady, has had this before, gets quite a few actually, a couple of times a week, and there's lots of family history of headaches. What do people think is going on?
Migraine.
Migraine. Yes, who said that? Very good.
That was me, yeah.
Well done. So migraine, yeah. So migraines, we get migraines quite a lot. Very common. You can either have with an aura, without an aura. It can be complicated or simple. You can actually have hemiplegia, and I'm sure you guys know a lot of this already. Or you can bacillus. So you can get some really funny signs. So kind of posterior cerebral arteries giving you diplopia, vertigo, tinnitus, which is not that common but can happen. Or they can be confused a little bit as well, which that's usually in the ones that maybe they've had it quite a few times, and we maybe know a bit more from the history. Okay, treatment wise, I've given the answers away, but symptomatic treatment is the best thing really when they're in the acute phase. So that would be, what would you give for symptomatic treatment?
Simple analgesics.
Yeah, so that's like paracetamol, ibuprofen. Yeah, anything else?
Antiemetics if they need them.
Absolutely, very good. Yeah, so they often do feel a bit sick. What do you think we normally do with these young people in the A&E department, apart from what you just said?
Reassurance.
Yeah, reassure. And like in the acute
keep
phase,
a diary, keep a headache diary.
Yeah, brilliant. That's really good. So I often say keep a headache diary, and I want to know what kind of things you're doing at the time, but also what foods you're eating, things like that. See if there's any triggers. Yeah. Anything else? So we would
try
normally
and put them somewhere quiet.
Yes, absolutely, which is really difficult in an A&E department, isn't it? So
if it's a teenager, heads assessment.
Yes,
for
excellent.
other.
Yeah, brilliant. I think that's a really good one. So for this one, if it's a teenager, I think a heads assessment would be really good. We normally try and put them in a quiet, dark room on a bed so they can just sleep it off. And actually 9 out of 10 times that does the trick, as well as some pain relief. The other things we can give are what we call the abortive treatments. So that would be things like sumatriptan. So, and that's normally, well, you can give it nasally, or you can give it orally. And that basically has to be given at the beginning of a migraine, and then a second dose can be given 2 hours later if it's carrying on. And I've had several kids come and see me in clinic, because I do a rapid access clinic as well as the PCD, who I see for migraine. And sometimes they say they work really well, and other times they say, oh, I didn't like the side effects. So it's all really depends on what the young person wants. And then you go on to preventative things. So I wouldn't normally give preventative medicine for migraines if they've just had like a one-off, or if it's like once every couple of months, because I think there's always a consequence to anything that we do, isn't there? And if you're giving medications, there needs to be a really good indication. So, but that being said, I have had patients come who are having headaches every week, 2-3 times a week. It's affecting their schooling, they're They can't go to school. They have to go home a lot. And those are the kids that we would give them preventative treatment for migraines. And so they go, first line would be a beta blocker. And then we used to give pazotifen to them as a first line, especially if they were younger. You can still do that, but I think beta blockers and topiramate are thought to be working a bit better now. And the beta blockers just be like propranolol. I did have a girl who had low blood pressure, so it was a bit difficult to justify beta blockers, and so she went on topiramate, which is an anti-epileptic, but that works very well for migraines as well. And there's often a family history, so it's good to ask the parents, do you get migraines as well, or headaches? Right, next one. 8-year-old boy having a frontal headache, feels quite squeezy, but it's really sore, and he's getting it in the evenings a lot of the time and doesn't like school. What do you think it is? Or what would you like to know?
Tension headache.
Yeah, it sounds like it, doesn't it? So it sounds quite benign. He's not got any other symptoms. He's going to school by the sounds of things. So he's not missing school, but and I think it's to do with stress for him. A lot of kids that get bullied do present with headache or tummy ache or psychological disturbance, and so it's really important that we delve into that a little bit and do a bit of a head assessment on him as well, even though he's 8. Think about what's happening at school, why are you being bullied, and how can we help? Every school should have an anti-bullying policy, which is what I tell all of our parents. So if your child is being bullied, their school have to legally do something about it. Okay. There's also some really good websites that help support. And if you go, I know it's for Lewisham, but if you go to mindkit.org, and if you do mindkit.org/Lewisham, actually, because obviously that's what I know, it comes up with a list of all the national support agencies, and bullying is one of the headlines there. So that's quite good. Okay, so tension headaches, usually due to times of stress, can involve the neck and the occiput, and it can be a continuous pain, but can be a bit throbby as well. They're not normally vomiting, not normally having abdo pain, unless they're also having tummy pain for stress and things like that. They're less likely to have a family history of migraine, and sometimes they've got depression. So it's really worth talking with them a bit more about this. Every school should also have a school counsellor, and we always give out the details of Kooth.com, which is free online counselling to our patients that come in with depressive symptoms. Okay, right, next one. So this is a real case that we had. So this is a girl who keeps coming with headache. Every time she comes to the department, she gets some pain relief, and then she seems to be doing a lot better. And every time she was examined, she had a normal neurological examination, but the mum kept bringing her back, and she came 5 times to the department. She'd also been having some fevers at the start of it, and then was feeling quite full of sinusitis. So she was starting antibiotics after the 10 days. Guidance of NICE is that after 10 days you can have antibiotics, but before that, unless you've got neurological symptoms or anything, you shouldn't be on antibiotics. So what do you think is going on with her? Any ideas? So she's, is that someone? So she's having these headaches, she's coming back, she's feeling really bad. So let's say on the 5th time she comes, and actually she looks a lot worse. She looks really unwell. So she has what's quite a not common complication of sinusitis, but one you must know about and can be missed, as in this case, until a bit later.
Is it mastocytosis?
So she had an intracranial abscess. So this can be a complication of sinusitis. So this is her MRI scan, and you can see in the frontal lobe on the right side that she's got an abscess there. So and if they get an intracerebral abscess or intracranial abscess, that's quite major, because she had neurosurgery and she needed to have antibiotics for months and months and months. And I'm not saying that we could have prevented this, because sometimes it just happens, but actually if we don't think about it, then we will get delayed presentation. So it's really important that we do look for it. So if you get someone coming with sinusitis who's just not getting better, I'd really recommend getting senior ENT review and to get a scan. Yeah. What's happened here is that the sinuses, are right frontal sinus, that's where she had a sinusitis, has tracked back with the infection into the brain. Okay. Right. So this one would need referral to neurosurgeons and discussion with neurology as well. Next one, 10-year-old boy, headache, very sudden onset. This is a real case. Screaming his head off, absolutely screaming, in pain. Never had it before. We gave him paracetamol, ibuprofen. What would you do next? Screaming, screaming, screaming.
Give us stronger pain relief.
Absolutely, yeah.
Yes.
So in our A&E, that would be intranasal diamorphine, which they sniff, or it could be Oromorph or IV morphine, excuse me, or IV morphine. What else would you do?
In terms of pain management?
Well, let's say you give them the strong stuff. Do you want to do any investigations, or what would you do?
CT head?
CT, yeah, great. So what do you think you might find on CT head?
Subarachnoid hemorrhage?
Well, it's a very good thought. So yes, subarachnoid hemorrhage. So sudden would be sudden onset, like a big thunderclap, but also venous sinus thrombosis. So he had a thrombus in his brain, which just seemed to come from nowhere, to be fair. So it was a bit surprising. But and with those, you would do your CT, make sure he's got adequate analgesia and anticoagulate him. Yeah. We'll also discuss it with neuro because obviously it's quite alarming, and it's unlikely he would need neurosurgery, but you might discuss if they had a big hemorrhage as well. Okay. What signs of raised ICP would you look for then, leading us on to intracranial things? What do people think? If you've got raised ICP, what might you see?
Papilloedema. You're doing in ophthalmology.
Yeah, Emma, that's a good one. So that would be quite a late sign, papilloedema. So if it's something super acute, you might not see it, but you should look for it.
Hypertension, bradycardia?
Yeah, so Cushing's triad, yeah? So you get hypertension. So the opposite, the way I think of it is opposite of shock. So when you're shocked, your blood pressure goes to your boots and you become tachycardic to compensate. It's the opposite when you've got raised ICP. So your blood pressure goes up and your heart rate goes down. You also get difficulty breathing. Your breathing gets affected. So that's your triad. Okay, great. Okay, 3-year-old, headache since they hit their head yesterday. Given some paracetamol and ibuprofen, and then just started vomiting this evening, and then is a bit more drowsy. What are you going to do?
CT brain?
Yeah,
CT
stabilize
brain.
the child first.
Yeah. So what will you do then? Let's talk it through. How are you going to stabilize them?
Neuroprotective measures according to the STRS guidelines.
Great. And what would that include practically for you to do in the department?
Raise the head end, prop the head up.
Yeah.
Normal blood pressure, maintain normal blood pressure as much as possible. Normal sugars.
Yeah.
They need IV cannula
Yeah.
and 3% hypertonic saline.
Yeah.
And referral to neurosurgeon, involve the consultant early.
Yeah, brilliant. So they're all really, really important things to do. The other things I would say is keep the head in the midline because you don't want any kinking of your arteries or neck veins. Try to keep them normothermic because if they become hyperthermic, that's really bad for them. They become hypermetabolic, and that's not. You don't want your brain to be overactive when you've got a brain injury. You can intubate them, and with these kids, I would intubate early. So if he's got a reduced GCS, you probably need to tube him right now. And then the question is whether you scan him or not. What do you think? Why do I ask that, do you think?
3-year-old with headache is a red flag. So they'll need scanning to rule out brain tumors.
Yeah. So you're absolutely, so I mean, this guy's had a headache since he banged his head, so it likely relates to the trauma. But what I would say is, if you think they've got a really bad brain injury like trauma and they're dying in front of you, you may just take them to neurosurgery directly. You may not even do a scan. Yeah, we always try to do a scan if there's time, but if they are so unwell and you think they just need to go to a neurosurgeon right now, or they're going to die in the donut of CT, then you take them straight away. Okay. What do you think's happening to this kid? Kind of mentioned it briefly. Why do you want a CT head? What are you going to see in a CT head?
Bleed. An extradural hemorrhage?
Coning.
So you can see all these things. So what kind of bleed do you think we would look for? So if it's not immediate, a bit later. So we've had a subdural because they're kind of slowly spreading, so they can sometimes present a bit later. Most bleeds will present in the first 4 hours. That's why if you look at the NICE guidance, it says in the last 4, we have to keep them for 4 hours monitoring. Yeah. So the Chalice study looked at head injury in kids and said these are the risk factors. So if you had a really nasty fall, things that are associated with the bleed are if you've had a fall from a big height, if you've had a seizure, all those kind of things. So they're the kids that automatically get a CT within an hour from when they first come in. So you're probably all seen the flow diagrams that we follow. But the rationale behind it is that most bleeds present early, whereas subdurals can present later. Yeah. So they're worth, if you've got ongoing headache and then change to GCS, that's very suspicious and you'd want to do a scan. Okay, so we need to do absolutely, like you said, neuroprotective measures, CT head, refer to neurosurgery, consider early intubation, okay, because he's going to lose his airway quite soon. If your GCS drops below 8, usually they say 8, that's when you need to intubate, or if they're tolerating a Goodell, that's about an 8, and that means that they can't maintain their own airway. Yeah, so you want to obviously transfer ASAP, but who will do the transfer? You're in A&E, it's the middle of the night, you've got to go to King's, wherever you're working, or your local neurosurgery centre. Who's going to do that transfer? Who's going to make that decision?
STRS?
Yeah, I was going to say your kind of local retrieval service will let you know if they can.
So it's unlikely STRS would do this one. And the reason why is that it's going to take them probably 20 minutes to get to us minimum, where I am, right? Somewhere in London, or even, or if they're in like the deepest, darkest, Margate or somewhere, and they may be busy, but it will just delay this patient getting to where they need to go. And they absolutely, if it's a bleed, an acute bleed, they need to get ASAP because the raised ICP is causing the brain to, become compromised. So we can't delay for STRS, so we have to take them ourselves. So that means you'd probably get your anaesthetic registrar to go, to be honest, yeah, rather than yourself. They go probably with a nurse and the anaesthetic registrar to the local centre. And it might be, and we've had it before, where we've just wheeled them straight to a surgical centre. They go through their CT and then they go up to them. And you don't wait for a CT where you are. Or it might be you get a CT and then you've confirmed the bleed, and then it's suddenly very urgent. You've got to get them across because it's very evident what you've got with you. Yeah? Okay. But you're absolutely right. Most of the transfers would be your local retrieval team. Okay, so got a 15-year-old young woman, long history of headaches, like a year, but decides to come today to your A&E department. This is real. Comes today because it's just worse today. And she's been taking paracetamol, ibuprofen, and she started taking dihydrocodeine because it's just not getting any better. What are your differentials?
Medication-induced headache.
Absolutely. Anything else?
Maybe like in benign intracranial hypertension.
Yeah, could be, yeah. Anything else?
Tension headache?
Yeah. Could be.
She had her eyesight checked regularly. Think about like needing glasses prescription.
Absolutely brilliant. Yeah. So long history to me suggests that, this is not something very acute. And, maybe that she does need glasses. Maybe the headache's worse at school. Maybe she doesn't. She sits at the front. I mean, good question is, do you sit at the front of the class or the back? And can you see the board? It's a bit of a screening tool. So yes, absolutely. So I would say medication overuse headaches quite high up on the list of my differentials here. And what would you do about that?
Get them to stop taking the medicine.
Absolutely. Stop taking those medicines that are giving you a headache. So, and think about alternatives. So we always talk about the biopsychosocial model of pain. Has everyone heard of that? I I can't tell if anyone's nodding, but that's what we talk about, especially with teenagers, because pain's very individual. So I feel pain different to you guys feeling pain, and you feel different than somebody else. And so I always say to our young people, your pain score, maybe a 4, for me could be an 8. It just depends on the individual, but we can manage our own pain using our bio kind of psychosocial factors. So the biome being the nerves being affected, the psycho being your psychology and how you use that, and then social being how you kind of interact with the world and what you can do to distract yourself, kind of thing. And a lot of our teenagers sometimes, or people coming with headache that are chronic, it's about more the biopsychosocial model than medication, because actually the meds aren't working. In fact, it can sometimes make it worse, like in this case. So good things are, I don't know, what does everyone think? Are there any good things that you would suggest to young people to help with pain that are not medications?
CBT?
Pardon?
CBT?
CBT, yeah. So talking therapies, that kind of thing. Yeah, anything else?
Acupuncture?
Yeah, could do.
Keeping active, weight loss, like apps, meditation apps and stuff like that on your phone.
Yeah, totally. All that kind of stuff. So it's about bringing that into the conversation, not just about medication. Because sometimes people are very fixated on, oh, can you make me better? Give me some medication. Okay, great. So 4-year-old, body aches, headaches, fevers, confused. It's a bit weird, isn't it? What would you like to know?
A little bit more about the history. How long has this been going on for?
Yeah. So
whether or not. Yeah.
No, sorry, Emma, come on.
How long it's been going on for, whether or not there've been any kind of focal neurology signs, or mum's noticed that he's interacting differently or can't walk, or those sorts of things, whether or not there was a preceding illness to it, whether anyone else has been unwell in the family.
So mum says, well, they were fine until they went on a holiday to see family in Ghana, and they've come back, and he got a bit poorly in Ghana, but he was okay, and now he's not very well again. Any thoughts?
Worried about malaria?
Absolutely. Cerebral malaria. So these kids can look okay, or they can look really shocking. So I don't know where everyone's working, but if you're working in London, you're bound to see some malaria at some point in your training. And basically needs bloods, admission, start antimalarials, and discuss with ID or haematology. It's really important to check a travel history. And I know we're in the middle of COVID and nobody's going anywhere, but people are going places despite that. And so it's still really important to check. Yeah, and then check if they've had any contacts. Okay, 15-year-old male, had a headache last week, rugby player, was in a bit of a bad scrum, had a bit of a head injury about 2 weeks ago. Pain in his head since then. 6 to 8 out of 10. Is using pain relief at home, helps a little bit, but he feels a bit dizzy, feels a bit sick. What do you think is going on?
Subdural?
So let's say he came in initially because he had a bad headache after the injury, and he had a CT and it was clear.
Might have developed since that CT.
Okay, so you want to CT him again?
No, more like a post-concussion syndrome sort of thing.
Who said that? Very clever, very good. Yeah. So post-concussive syndrome. So actually, this is what for concussion is the advice you would give them on the screen. I don't know if you can see that, but hopefully you can. Simple analgesia: rest. Try not to do things that make you more headachy. So I've got a kid at the moment who I'm seeing in clinic who's come with this, and he is playing video games at home. It's making his headache worse. So I've said, please stop playing video games and don't do any sport for a while. And it basically is a real pain in the bum because it can last for months. If you go onto what's called Headway, the brain injury charity, they've got a really nice information on that, and I often direct families towards that because it can last a long time. Yeah, great. If you've got any questions as we go, guys, please do ask. Then we've got a 5-year-old, headache for the last few weeks, started vomiting this morning, and now a little bit wobbly. What would you like to do?
Imaging.
Yeah,
Like a
imaging.
space occupying lesion.
Very good. Yeah, so he has got a brain tumour, sadly. So so you do CT head acutely. You probably want to do MRI really, but actually overnight CT is the emergency choice. Obviously discuss oncology, bloods, speak with the family. And I would just say one nice thing you can do for the family, although it doesn't feel very nice, is to warn them about going to an oncology ward. So to say that if you're not clear what any kind of cancer is in any child, not just a brain tumour, but if you think it might be, to tell them that when you go to the ward, there will be children there that don't have any hair. It's a cancer ward, so that when they get there, because there have been cases previously, I mean, not here, but I think, but when people have gone across and it's become a real shock because no one said the word cancer, but they have used the word like a tumour or, you know, discrepancy in the blood film or something like that. So we've got to be quite fair with families and give them that choice. Cool. So do you all know about the brain tumour charity? What's it called? Head. Ugh. So I got this from
HeadSmart.
HeadSmart. Thank you. My COVID brain going on there. Yeah, so HeadSmart. So these are what you get in children, but it's a really good website if you don't know it, where you can just look at the symptoms in babies, children, or teens, and they have any of these things. So you might be working in the clinic, you might be working in A&E, where they have these things. And actually, persistent or recurrent headaches are a difficult one because, like, a lot of people with headache have recurrent headaches. But I think if there's any concern about, you know, a space occupying lesion, you've got to scan them. And normally I would MRI if I could before a CT. But if it's out of hours and we just need to know, a double bank holiday weekend, because you know that's when they're going to come in on a Friday evening, then please do a scan. Yeah, great. Next one, very topical. So 2-year-old holding their head, looking miserable, quite clingy, but quite still, having some fevers, and parents just think that vaccines are evil and that we're evil for giving them. So what do you think is going on here?
Meningitis.
I think definitely until proved otherwise, this could be meningoencephalitis, couldn't it? This actually was so I think meningoencephalitis is whack top of your differentials, but when we examine this child, they've got a lot of lumps in the neck. So when I say clingy but still, they're not moving their neck. So we were worried that they would, you know, had a stiff neck with meningitis, but actually they had lymphadenitis in their neck, and I think they were just a bit dehydrated. So it wasn't that, but the treatment was the same. We just gave ceftriaxone cover, and then actually they perked up a lot with that, and in the end we didn't do an LP. So it could be, I think you have to think about that, but you also have to think about other things as well. Okay.
Isn't there like a measles encephalitis or something?
Yeah, definitely could be. Do you all know about measles? Have you ever seen measles? Anyone ever seen measles? Probably easier question.
I have. There was a
You have?
outbreak at yeah.
Yes, we did, didn't we?
Yeah, I've seen one at Lewisham, Ben.
Yeah, so we do get some. Yeah, it's not super common, but you tend to get outbreaks. And so I think once seen, it's a lot easier to kind of keep it in mind. But because of the MMR, well, let's call it scandal of your man who linked, what was his name, Wakefield, that's caused a lot of damage, a lot of mistrust of professionals. And actually, we're seeing a lot of anti-vaxxers now. You're probably all seeing it in your hospitals too, of parents with the COVID vaccine and things like that. So whenever I ask a patient now, like and a family, have they had the vaccine? So they're like, no. And I was like, have they had their normal vaccines, you know, kids ones? And they're, oh yeah, they've had them. So just sometimes we're just double checking. Yeah, so not always simple. But with measles, yes, you can get like a really nasty meningoencephalitis. Chickenpox, you can get like a meningoencephalitis. It's really important that you safety net kids when they come into, because normally I like to kick these kids out really quickly because they're really infectious. So ideally from triage. But if they've got abnormal OBS, then it's difficult to do that. But if you think somebody's wobbly on their feet, then that's not a good sign. That's normally steady. Then you think about meningoencephalitis. Cool. Right. 8-year-old, headaches in the summer, running around, otherwise really well, bit constipated. What do you think's going on? This is the commonest cause of
Dehydrated?
headache. Pardon?
Dehydration?
Dehydration, absolutely. This is the commonest cause of headaches in kids. So we often rehydrate them in the ED because they often, and also if you've got a headache, you don't really want to drink, do you? So, but we do try and rehydrate them. What's the second most common, I would say? Someone's already mentioned it, actually.
Tension headache?
Pardon?
Is it a tension headache?
Well, probably it's right up there, but I'd say not getting glasses and having visual problem and straining and affecting them with their tension headache and also, straining headache. So I think, really good to ask them, have you had an eye test? Yeah. Cool. Right. That's quite a lot of headache. Any questions? I don't know what's the time.
Yes, with the migraine management, the nasal sumatriptan, is it something we can start in the ED?
It depends on your ED, but potentially yes. I don't know how it works where you work, but I'm going to take the show off now so I can see people. Is that okay? That's basically the end. There's one more slide, but it just shows you what we talked about. How do I do that?